Good evening. I hope most of you are still awake. So I'm covering two topics, the interventional headache management and peripheral nerve blocks. Just to give you a follow-up, the patient that we did occipital nerve block has gone down from VAS of 7 to 2. The husband has just called me, and both of the pain are now almost gone. So headache has been a long-term problem for me because my mother had suffered all her life because of headache, and at least twice a week she would be in bed because of that. And then my wife, ever since I met her in 1992 till recent past, had constant headaches. So when you see headaches and you wonder what's happening, the last account that I knew of the several books and several journals, I knew that the pain comes from intravascular, the intracranial part. And then recently last year, what happened that I saw a case of auriculotemporal neuralgia, and then the focus went out extracranial. So now this became a very interesting journey, and we started doing more and more of these headache blocks, and I'm presenting my experience of last 1 year of 93 cases. So I believe now that we should focus much more extracranially than intracranially. One of the first conclusion which proves that it is extracranial was done by Professor Guyron when they did an electron microscope and proteomic comparison of trigeminal branches of these nerves, and they showed that there is dysregulation of myelination process in patients with migraine headaches compared with controls. So this was the first evidence. Another thing that I wanted to draw your attention to is a beautiful paper written by Ronald Melzack, and this was in 1990, Pain and the Neurometrics of Brain. And this is something which shows you the mechanism of chronic pain, which has got no survival advantage. Of course, this topic is so big that it requires a separate presentation, so I'll just touch from outside. It just says that the patient, every person has got 4 components. The one is a body self neurometrics, which is a 3-dimensional perception of pain. And then there is cyclical processing and synthesis in which the neurosignature is produced. The sentinel neuron hub, which perceives or which converts the flow of neurosignatures into the flow of awareness, and then activation of an action of neurometrics to provide the pattern of movement to bring about the desired goals, which means that patient with the chronic pain can have a particular gesture or a particular body posture. So this is a paper you must read before you start treating the chronic pain syndromes. So in short, it says that there is no pain cortex, so there is no specific target which you can manipulate. So we expect the sensory, just like we expect sensory and motor cortex where we do surgeries or lesioning. So with this, I would come back to the headache. So Guyron was one of the major person who did a lot of migraine surgeries, and he classified things into from site 1 to site 6. Site 1 is supraorbital supratrochlear nerves in the frontal region. Site 2 is temporal zone, which is zygomatic branch of the temporal. The rhinogenic trigger zone is site 3. The lesser occipital nerve is site 4. Site 5 is auriculotemporal nerve, and site 6 is greater occipital nerve. Now I would like to give attention, and most of you should remember them, that there are these 3 points on the temporal side, then few points here on the forehead, and then these are the secondary points, these are the trigger points, and posteriorly 1, 2, 3 and 4 points on each side, which can show you that the pain is coming from here. Any headache patient comes to you, if you just press these points, you will come to know that the trigger is coming from somewhere these points. In chronic patients, you can have all of these points activated, so we have to wait till we reduce the mutual induction of these nerves because of chronic pain. I would also like to draw your attention to this dissection, where you can see that there is a huge anastomosis happening in all of these branches from front to side to back, and then because of these, the pain in chronic migraines or chronic pain for the headache, it means that it is spreading from everywhere to everywhere. It may start from the back, it can go to front, and I'll show you that these patients who I have seen, I have a patient who had continuous headache for 24 years, entirely devastated life, sold her house, husband left her, job was left, became very poor, traveled 3 countries, and still she had headache. I'll show you that case later. So anterior to auricle, there are supratrochlear and supraorbital nerves. Then auriculotemporal, which is V3 on the side, and the zygomatic temporal nerve, which is V2. Posterior to auricle is lesser occipital, C2 and C3, greater occipital, C2, and third occipital, which is C3. So posteriorly also, lesser occipital nerve and anastomosis with great auricular nerve, which is the cervical plexus, and with occipital branch of posterior auricular nerve, which is in turn a branch of facial nerve. At vertex, we have accumulation of all these nerves, and then so vertex, sometimes patient will come to you with only vertex pain or vertical pain. In a nutshell, there is a rich anastomosis across the scalp within the branches of trigeminal, facial sensory, and cervical plexus. Now, these are the triggers which are in the temporal region. Particularly, if you see these zygomatic temporal nerves, if a patient comes and says that my trigger or my pain starts from temporal region, then you have to ask him whether the pain is outside the hairline or inside the hairline. So this, if it is outside, then it is a zygomatic branch of the temporal, or if it is behind the hairline, then it should be auriculotemporal nerve. And it all started with a guy who came to me who had traveled 3 countries to get his pain treated, where he had pain only related to this region, which was auriculotemporal nerve. So he just jokingly told me that, can you cut this nerve which is here, whatever it is? And I said that, okay, I can cut it, but I don't know what will be the result. But then I pondered upon few papers which were describing auriculotemporal neuralgias. So now, instead of going into the types of migraine and cluster headaches, I would say that most of these are just neuralgias. And the more literature you would find, you would realize that these are exactly like trigeminal neuralgias, where either a tissue band or a blood vessel is overriding a vessel which is causing pain, and that's why we also get throbbing pain. So if you start thinking extracranial for headache, you would find so many answers, and these are so easy to treat. This particular point is called as a vulnerable point for zygomatic temporal nerve, and most of the pain it comes from here, even because some patient has got too much tense, the muscle hypertrophy happens because they are clenching their jaw. So these two muscles, they can actually have pain because of very tense musculature, which becomes hypertrophic with time. Now, another thing which you should know, that the descending nucleus of the trigeminal nerve, it goes down, and this is the one which is particularly carrying this pain sensation from the face and then from the throat, which interchanges information with the C1, C2 and C3, which is supplying the posterior. So if you've got patients who have so much of pain either coming from the front or in the facial region, which is then referring to the back, or they can have a back pain, occipital pain, which is coming to the face. Like today's patient, she was complaining of pain of the occipital region, which is going typically up to the vertex, and then she was also having referred pain in the eye and in the ear. So now, how to tackle the individual zones? First of all, we'll see the orbital frontal zone, where we usually get a supraorbital, supratrochlear nerves. It is very easy to palpate. All of us know it. Most of the neurosurgeons know right from their ICU or their Glasgow Coma scale examination. So we have always elicited pain in a comatose patient. You can have several types of bands over here. This blue is a fibrous band. So with this fibrous band actually converts this partial fossa into complete foramen, and it can be of various types, type 1, type 2, type 3, although it doesn't matter when you're doing a surgery or first you're doing a block. So it can be a simple band, it can be a band with a division, it can be a band called as inversity, it can be a band with a calcification nodule, or it can be a band with a partial bony canal, so that there are 2 foramen, one is supraorbital and another is supratrochlear foramen, or there can be no foramen. But when you are treating them, it's more important is whether they are tender or not, whether they are a trigger point or not. Another thing which also can cause pain is the glabular muscles which are here, which can also, the nerves are supposed to go from behind the belly of corrugator supercilii muscle or these glabular muscles. But another trigger point can be here, and there are now endoscopic subgaleal surgeries happening. Plastic surgeons are doing for a long time. I wonder why neurosurgeons are not doing them. But I intend to do them, and we are actually looking for cases. But right now, my patients are so happy with the blocks. So this is where we can do the blocks. Although from the midline you go up to 2 to 2.5 centimeters and you can find these trigger points, but I always rely on trigger points. You push them wherever there is sharpest pen, you mark them with a marker pen, and then you can block it. So this is the orbital frontal subgaleal surgeries which can be done. Though we're expecting maybe next year, if I present something like this, we have some experience of doing these endoscopic surgeries, but for now we have patients who are extremely satisfied with the blocks. So temporal region, this is very simple, 3 points, and then this is the zygomatic branch where you can push it, and then so there are usually 3 points. You go behind the line, you can go to the auriculotemporal nerve, you can go to the zygomatic temporal nerve just behind the orbital margin. So this is the surgery that I did for first as a auriculotemporal neuralgia, where we found that there was a blood vessel which was tortuous superficial the temporalis artery, which was over the nerve. So I did 2 surgeries. I cut the zygomatic temporal nerve, but auriculotemporal nerve we just decompressed vascularly, and patient got a complete relief. In occipital region again, usually these nerves, they have an interaction like this one. You can see either it can be perforated, it can be looped around, or it can be pressed by. And then if you press these points which are there, then you would find most of the pain is coming from here. And then you can start doing the injections. So these are the cadaveric studies where the history of the patients who had headaches. And they were found to have the bands like these. And then you can also see that the occipital nerve is perforated by an artery, an occipital artery. And these are the live surgeries done in some patients. Now another question is Botox versus local anesthetic, and I would say that Botox is not required, although they are very frequently described in the books. But when the trigger is a nerve which is in turn causing a muscle contraction, why don't we relax the nerve? Why don't we tone down the nerve so that the muscle gets toned down automatically? That's how I do a lot of selective dorsal rhizotomy procedures. There's no point in cutting a tight muscle when you can cut a nerve and reduce the neural output. So similarly that. So I don't know why Botox is given. I'm not giving. It's very costly compared to just local anesthesia, and I'm getting pain relief up to 6 to 8 months. In some cases, even up to 1 year. So these are the certain landmarks which I just want to give a reference for occipital nerve. Then we'll go for some cases if you want to know. Can we get an audio output? चल नहीं रहा. Okay, maybe the video is not, but you can see this patient is weeping, and she kept coming to me. She needed 3 sittings over 6 months. She was pregnant, so we couldn't give her medications anyways. But then after 3rd sitting, she has got more than 90% relief. This patient, 4 years of persistent headache, almost daily, completely satisfied. Now this patient is the one I was talking about. She was working in Kuwait, and then because of too much absenteeism, she was removed from the job. And then her husband left her. Then she had to sell her property. She went to USA, UK. Nothing happened. For the first time, we gave her a block. And then now with the 2 setting of injections over 6 months, she has got more than 80% pain relief. Another girl, her head was thrown against the wall in a madrasa. She had a headache every day for last 19 years. And then I gave her injection, and then you can see that she's very happy after that. So in a nutshell, just remember these points and start hitting them. And very soon you will become an expert doing all of those things. And so 93 cases, 76 females, 17 males, average age was 38, youngest was 14 years. Average duration of relief was 4 months. Average benefit of VAS was 6 points. And return within 7 days was 6 cases. Low grade infection in 1 case. No hematoma, no failure. One more thing which I want to show here I needed time for that. I already told that something which was not covered in disc pain management or spinal pain management was toxic annular tears. Am I allowed to speak?
So I think we can conclude as it is.
2 minutes. Okay. Because without this, if you don't understand this, then I think we are not doing justice to spinal pain management. Anyone sees anything in this MRI? This one, yeah? How does it look like when we do endoscopy? It looks like this. This is called as a toxic annular tear with so much of neurogenesis over here, a lot of toxic fluid going from here outside, irritating the dura, something called as chemical neuritis. And then outside there's at this area, there's dorsal root ganglion. Severe pain happens to the patient, yeah? And if you see this patient is not able to raise his head, this is one of the tests, McKenzie's test, yeah? Severe pain. I just did a disc block here. We gave steroids and local anesthesia here, and patient is walking for the last 5 months. This female, again, a very tiny hyperintensity area here, okay? Not able to walk, not able to do any work. Then we found that there are 3 toxic annular tears, and then we did the steroid injections here, 3, and she started working right from the next day. Severe pain she had. Immediately you can see she is able to hyperextend her spine. So this is very important. If you can find these hyper dense zones, then like this one, you can see there is a hypertrophic, almost squarish dorsal root ganglion. DRG block and disc block have not been discussed here. If you had a case, I could have shown you how to block them. One more case, I would say we put, there was a patient who had an intracanalicular screw placement, very beautifully done. Then I removed it after 11 years. And then we put a cage here, but somehow after that she had severe pain. So I did a radiculogram that you can see here. She had severe pain. If I show you this video, she was weeping overnight. I don't know, I'm seeing there, so, but she used to weep a lot. And then you can see we did a block of dorsal root ganglion. And then even in the operation theater, the very next day she started dancing. So that's the magic of disc block and a dorsal root ganglion block. Then again, I was telling about the peripheral blocks and the pseudo-unipolar, the role of pseudo-unipolar neurons, because dorsal root ganglion has one. That means both the axons, they work as the same thing. So whatever you do peripherally starts happening centrally. So if you have a patients like any patient with leg pain or disc pain, just press here, clinically here, common peroneal nerve branch or sural nerve or the posterior tibial nerve, you would have a patient will complain pain even up to neck. And if you block here with just diluted xylocaine, then patient would have magical relief, right? This patient had a severe cervical pain which was going all the way down. I gave him injection here, and after that now it's more than 7 months patient has got no pain at all. Again, if you see this lady walking like this for 2 years, I gave her a peripheral block and she started smiling. Third patient, not working, but this patient was lying down in front of my clinic when the clinic was closed. Pain going from the leg all the way up to the cervical spine. And we gave her local blocks and she is still 4 or 5 months, she is very happy. So these are very important ones. You can sort them out in your own OPD. You don't need to do anything else. And many patients will thank you for even up to 6 months. Thank you so much.
So what is the reason for having a pain right from top, that is from the head to the foot, they have pain and you block them?
Well,
what is the reason of pathophysiology?
so one thing is that there is sensitization of the sympathetic system because the involvement of the dorsal root ganglion. And we have variable, like today I elicited the patient had pain, and when I pushed her here, the pain was going all the way up to elbow. It all depends upon what is the duration. So that should be one of the reason why it is there.
Called psychogenic pain. So that is the reason why pain was
Sorry? A DRG block is particularly you should do when you are seeing a toxic annular fissure right over the DRG from the disc. If it is directly releasing the chemicals over there, area is slightly different. I wish I had time in OT today, I would have explained that with the same transforaminal, you can go to the disc, you can go to the root, and you can go to the DRG. Much better results than epidural, I can tell you that. Sorry? When they come to me, they already medically managed so many times. What medical management we could do? Just painkillers. Remember, when there is a toxic annular tear, which is not discussed today, the neurogenesis keeps on happening. Right. I have another presentation which says endoscopic visualization of pain generators in spine. The nerve generation will keep on happening and the nerve endings will get thicker and thicker, meaning same tear is going to give you more and more pain with time. So there is no logic and reason why you should be conservative with them. And after all, they are just injections. What? I'm not getting you. Can someone give a mic? So there are certain diagnostic processes, like if you press, I told you the peripheral points, if you can press and patient says that there is severe pain, or if you keep the patient prone, and then, so these are called as Goretz sign and Mackenzie sign. If Mackenzie sign means when you allow the patient, you tell him to hyperextend spine while in a prone position with hands behind, and the pain goes all the way to the leg, then or the pain localizes to the spine. That's the time when you have to do these injections.
Because we see such scans almost sometimes in our routine practice. We see such MRIs in our routine practice many times.
I have one case which I could not discuss here, that she had a problem, and again when I was in a big hospital here where they won an award for best spine department, there was this high intensity zone in the disc, and they do a screw fixation on that patient. Patient doesn't get a pain relief. Then that patient goes to, from Kenya, they came to India, they got a surgery done in Ahmedabad, they said 2 more screws are required. So from 2 levels, they go to 3 levels. Patient has got the same pain. I have got a video of her, we don't have time. And I just gave her a peripheral block and she said in 4 years for the first time I have got a pain relief. So many times we don't understand at what we are doing by neglecting such cases. Yes. Yeah, so if patient has this problem, that means already the dorsal root ganglion is sensitized. And if you do that, first thing that patient would know that this guy can treat my pain. Just like with headache. So many patients come to me who have traveled so-called 2-3 countries. And when I'm saying that is it the pain? And they say exactly this is my pain. I said, did anyone elicit this pain? Or did anyone recreate your headache? They say no one did. That means that person knows that where the pain is coming from, that means I can treat. So you get a patient's trust and a short-term pain relief. If you are to do a peripheral this thing to exploit the state of being pseudo-unipolar neuron, you just do diluted xylocan, and there are several papers on it. You can read them. Yeah. It's a magic. I have a patient's video, she's saying it's a magical injection. So
your talk on the extracranial management of headache is excellent. So I really hope that you publish your data. It will help a lot of pain management.
Definitely, we are very closely observing all these patients. It's very interesting. So my teacher, one of my teacher, he told me only this point, but I press everywhere. Okay, because it all depends upon which dermatome it is coming from, C4, C5, C6, we don't know. I have done that also because I could see that there is a problem in the disc, and I did that. Even then patient got a relief, but more relief if patient has got this pain. But here only use Xylocard. patient will go into hypertension.
I think, sir, we have
Here,
to
it was high.
because there will be many questions, I'm sure. Yeah. Sure, we'll
Now,
have
this will enrich
a-
your clinical practice, you don't even know that.
Thank you very much
so much.
for the wonderful talk and eye-opening talk. And that brings us to the end of the session.